Good day, dear great surgeons. Today we're gonna talk about a very interesting subject, oncosurgery and the transplantation surgery. Those are revolutionary chapters and very important in the exam. They will be with minimal questions, but you can gather them up. So let's take this journey together with those voice shots to sum up this chapter.
Sudden loss of urine output is the most commonly due to blocked catheter. However, if this is excluded, if the blocked catheter reason is excluded, the most worrisome cause is arterial thrombosis, especially when we are talking about renal transplant. This will often be delayed diagnosis and the rate of graft loss is high. So take care. Chronic rejection of renal transplant is mediated via T lymphocytes, and therefore it's a type 4 hypersensitivity. Types of organ rejection, either hyperacute, acute, or chronic. Hyperacute organ rejection. Hyperacute organ rejection occurs immediately at the time of the transplantation on table. This occurs immediately through the presence of preformed antibodies such as ABO incompatibility. Acute organ rejection. This occurs during the first 6 months. Take care, 6 months, the first 6 months, and usually T-cell mediated, usually tissue infiltrates and vascular region. Chronic organ rejection. It occurs after the first 6 months. So the first 6 months, if occurred, acute. After the first 6 months will be chronic. We have many terms we have to be aware of regarding the transplantation type. It all ends by graft and start with allo or iso or auto or xeno. Let's start with allograft. Allograft, those are transplantation of a tissue from genetically non-indicated donor from the same species. While isograft is identical twin. Graft is a tissue shared between individuals who are genetically identical, like twins. Autograft is transplantation of organ or tissue from one part of body to another part of the body of the same individual, like the skin graft. I will take my skin graft from place in my body to another place in my body as well. This is the autograft. Or take my blood to give it to me from the life-saving or blood-saving machine. So this is autograft. The xenograft is tissue transplanted from another species, like broken heart valve or even the skin of the pig. This is a xenograft. Remember, in kidney transplantation, apart from the ABO matching, HLA-DR, the human leukocytic antigen DR, is the most important following the ABO matching in kidney transplantation. Remember, immediate rejection is due to the presence of pre-existing antibody. This is a hyperacute rejection due to ABO mismatch. The transplanted organ should be removed instantaneously. Nephrostomy tube is a drainage tube that is placed in the kidney to drain the urine directly from the kidney. In renal transplant, a nephrostomy tube is important to know whether the kidney is functioning or not, or it's just the catheter is blocked. Because renal shutdown first sign is due to low output urine or anuria. So after operation, the kidney must be performing even if oligolytic. So the mainstay will be the monitoring of the nephrostomy tube. If the nephrostomy tube is working, so it's post-renal cause, like either ureter obstruction or the catheter obstruction. From the very famous technical complication of renal transplant is the renal artery thrombosis, renal artery stenosis, and renal vein thrombosis, and of course urine leak or lymphocyle. After renal transplantation, renal artery thrombosis must be in mind because it will be featuring sudden complete loss of urine output and will be managed by immediate surgery, which may salvage the graft, delaying beyond 30 minutes associated with high rate of graft loss. So save your graft, please. The renal artery stenosis. It will be presenting by uncontrolled hypertension, allograft dysfunction, and edema. The management will be angioplasty. Renal vein thrombosis after renal transplant. It will be presenting with pain, swelling over the graft site, hematuria, and oliguria. The management will be nothing because the graft will be usually lost. Lymphocyle after renal transplantation. It's a common complication occur in about 15% of the patient will get to you with lymphocyle after renal transplantation. Hope not, of course, but they might come. If large, it may compress the ureter. The management will be drainage with percutaneous technique, ultrasound guided via the interventional radiology, and sclerotherapy or intraperitoneal drainage may be needed as well. By the way, the lymphocyle after organ transplantation, after renal transplantation, for example, don't generally occur until 2 weeks or longer after the surgery. They are, however, relatively common. About 15% or 18% of the patient will come with lymphocyle. The symptoms: mass effect or compression adjacent structure. Mass effect, which is compression over the adjacent structures. And this will include vessel supplying both the graft with deterioration in the graft function, the ureter will be alterated in urine output, and the recipient lower limb will develop leg swelling and edema, bilateral lower limb edema. And the creation of laparoscopic or open peritoneal window is favored treatment. The long saphenous vein is one of the commonest autograft in surgery. In renal transplantation rejection forms, you will see neointimal hyperplasia of the donor arterioles, which is a type of chronic setting. Again, it's type of chronic setting, not hyperacute. Cytomegalovirus, the CMV, is the most common and important viral infection in solid organ transplantation recipients because they are merely immunocompromised. The primary infection with cytomegalovirus will typically occur 6 weeks after transplantation in a seronegative individual who receives an organ from seropositive donor. The symptom may occur as early as 20 days, but can occur up to 6 months post the transplantation. The symptoms are mostly vague, often vague, and like retinitis can be pathognomonic, but rare to be seen in the transplantation population. Cytomegalovirus disease is seen about 8% of the renal transplant patient, and intravenous gansilovir is the treatment of choice in such a patient. Unfortunately, relapses are not uncommon. Remember, non-steroidal anti-inflammatory are very good choice for analgesia, but they are nephrotoxic. Therefore, they are usually avoided in the patient who have undergone renal transplantation. Remember that paracetamol and morphia are used in the renal transplant patient because they are metabolized predominantly in the liver. By the way, to be precise, morphia predominantly metabolized in liver, but it has some renal contribution in renal metabolism and excretion. So, the morphia should be administered in reduced doses in renal transplant patient and should be avoided if the transplant kidney stops functioning. Take care, cyclosporine is very famous for nephrotoxicity. Remember that alopecia is associated with athioprine and diabetes is associated with the tacrolimus. Again, diabetes is associated with tacrolimus, alopecia associated with athioprine, nephrotoxicity with cyclosporine. Did you know that the first time of renal transplant, typically implanted in the left and right iliac fossa, and the vessels are usually joined to the external iliac artery and vein, and these are the most easily accessible arterial supply and venous drainage. The Rutherford-Morrison incision provide access to the external iliac vessel very sharp. Renal artery stenosis in renal transplantation typically occur over several months and will usually result in the development of hypertension. Most cases can be assessed using the duplex scanning and managed with angioplasty. So again, in renal transplantation, the hyperacute rejection, minutes of the clamp release in the OR theater. The accelerated acute rejection occurs in few days following the surgery. The acute rejection after 24 hours from the surgery and before 6 months of the surgery, before 6 months away from the surgery. The chronic graft rejection will be after 6 months from the onset of the surgery, because before 6 months it will be acute rejection. Again, hyperacute graft rejection is due to the pre-existent antibody to the human leukocytic antigen, the HLA antigen, and is therefore due to IgG mediated. Remember that IgG, G for gold. Gold is old. And of course, it will be against the recipient. So the host have been exposed to the recipient by where else, by any mean, and decided to make antibodies against this recipient way before exposure during the renal transplantation. That's why he has a preformed antibodies against the recipient graft. So the antibodies is old already and pre-made. This is a IgG, gold old antibody. Okay, hope it's clear. You are doing great, by the way. Take care, corticosteroids may be given to reduce the risk of the graft rejection, but take care, at higher doses they are able to induce apoptosis of activated lymphocytes. Necrosis is a different process and not induced by steroids. Take care, apoptosis is a programmed cell suicide, while necrosis is uncontrolled cell death. Tacrolimus is metabolized by the 450 enzyme system. Again, tacrolimus is metabolized by B450 enzyme system. And this is inhibited by a number of naturally occurring substances, like the watercress, grapefruit. Both inhibit this naturally. And this should be avoided in immunosuppressed patients taking the tacrolimus. Remember, right-sided liver donor transplantation are extremely rare. This is because the vena cava precludes the metabolism of the right renal artery. The short right renal artery that is produced therefore presents a major challenge. The sudden cessation of urine output is the context of highly suggestive of acute thrombosis. So, sudden cessation, sudden stoppage of the urine output means acute thrombosis mostly, and delay in thrombectomy beyond 1 hour is inevitable, and graft will be lost inevitable. It's a serious problem. Take care. Granuloma. Granuloma are mainly histiocyte macrophage cells. So, histiocytes, specifically macrophage, are the cells that define the granuloma. They are often, but not invariably, fused to form multinucleated giant cell, like the Langerhans giant cell. So the macrophage granuloma refer to epithelioid. Hamartoma is non-cancerous tumor made of abnormal mixture of normal tissue and cell from the area in which it grows. Hamartoma can grow on any part of the body, including the neck, face, head. In some cases, hamartoma grow internally in places such as the heart, brain, and lung, and even the colon. Remember, the whole trick about the hamartoma is non-cancerous tumor, non-cancerous growth. It's benign.